Good evening, friends. It's a great pleasure to welcome you to the Dialogues on Primary Healthcare, an initiative set up by the Center for Primary Healthcare at BHS and by the Center for Healthcare at IIM Udaipur. BHS or Basic Healthcare Services is a not-for-profit organization driven by the vision of enabling marginalized and vulnerable communities lead a healthy life with dignity. Through a network of primary healthcare clinics, BHS provides healthcare to rural and tribal populations in the districts of Udaipur and Dungarpur in southern Rajasthan. BHS is setting up a center for primary healthcare with a vision of a place that makes freely available knowledge, tools, training, and technology to design, implement, and evaluate primary healthcare services for the marginalized. The Center for Healthcare at IIM Udaipur focuses on healthcare-related research from a management lens. The center acts as a platform for researchers, practitioners, policymakers, and other stakeholders to come together to create evidence-based impact. The Center for Healthcare is currently prioritizing research in the primary healthcare space, given the paucity of research on this topic from India, about India, especially in the management space. The dialogues on primary healthcare, the first of which is happening today, is a series of conversations aimed to generate evidence and experience informed discourse on practice and policy of primary healthcare in India. While there is reasonable evidence that health systems founded on strong primary healthcare are effective, resilient, and cost effective, there is not adequate understanding on how to design, build, and run such systems. The series invites speakers who have deep experience on practice, research, or policymaking on primary healthcare and its different aspects. They will share evidence and insights from their own research and practice and discuss their implications on larger primary healthcare ecosystem in India. With that, I request Dr. Pavitra Mohan to introduce today's topic and today's speakers.
Thanks, Prakash. Following the Bhore Committee's report, which many of you would know of, which was submitted before India's independence, India's healthcare system was established on the foundation of primary healthcare. And that then led to a large network of PHCs, CHCs across rural India. Following the Amata Declaration in 1978, it reaffirmed that India's design of primary healthcare based on primary healthcare is a sound one, and it also underscored the role of government in ensuring healthcare for its citizens. In recent years, the COVID pandemic brought back the attention to primary healthcare and brought its attention as essential for a health system that is resilient to events like the pandemic. However, there has also been in past several years a greater debate on the role of government in delivering primary healthcare and also of adequacy of primary health center-based health system in meeting needs of the times. It is in this background that today's first discussion, of the conversation of the series is focused on public health system delivered primary healthcare. And to my mind, that there are two kind of very significant research that I often draw from. One by Dr. Sudha Ramani on evolution of primary health care in India, and the other one by Dr. Ritika Kheda over the years on status of primary health centers in Rajasthan. In this episode, based on their own research, the two speakers will discuss the evolution, current status, and future directions of publicly delivered primary healthcare in India. I'm very happy to welcome the two speakers, Dr. Ritika Kheda. She's an academician and activist, a professor of economics at the Department of Humanities and Social Sciences at the Indian Institute of Technology, Delhi. She occupies the Narendra and Chandra Singhi chair at the institute. She has worked extensively on the issues of social policy, such as health and nutrition, poverty and inequality, education, employment, social protection, and the use and misuse of technology. Our second speaker is Dr. Sudha Ramani. She is a researcher and researches issues pertaining to health policy and systems, qualitative evaluations of public health programs, and also is engaged in teaching and training people on health system thinking and research method. So very happy to have both of you here, Ritika and Sudha. To begin with, I would request Dr. Sudha Ramani to share her research, which I presume was part of her PhD program a few years ago on evolution of primary healthcare and how do contextual factors affect the design and implementation of primary healthcare in India. So over to you.
Thank you, Dr. Mohan, for the very kind introduction. So I'll just share my screen. I have a quick presentation, and then we can take it from there. Okay. So again, thank you to everybody for joining us on this long weekend to listen to this presentation. And as Dr. Mohan had said, today's presentation that I have, it's based on my doctoral work. It was published a few years ago in BMJ Global Health. It's also one of my own personal favorites also because it asks a seemingly very simple question. What happened to primary health facilities today? But it ends up in with extremely complex answers that we explore in this particular paper. So in this slide, I've just shown an image of a primary health facility, and that many years ago, even before independence in 1947, we had this grand vision that the primary healthcare system in our country would play. They would be these. They were designed to be wonderful social institutions. They'll be the backbone of our health system, and they would provide healthcare for all. These were some of the thoughts we had, but the reality today is that much of primary level care, especially the curative one, the sardi, khasi, the stomachache, all that happens in the private sector. And the facilities that we now have, they provide very limited services. They have limited drugs, equipment, and so on and so forth. So I try to ask this question: what happened to this grand vision? Why did this original vision that we have? Why did it not translate into reality as we see it today? Uh, so again, a question like this you can answer in many ways. But we felt that some of these answers they lie in the sort of the historical choices that we have made. And so maybe studying history will give us some of the answers. But having said that, history is definitely not straightforward to understand. And one way to get a better understanding of history is to read our policy documents a little bit in between the lines. So not just look at the content of policy. For example, if the National Health Policy 1983 is saying this, what does it mean? Why was it so important to put a particular sentence into a policy? Why does the report not say anything about primary health care and things like that? So to get a good reading on the policy, one moves beyond just reading the content and trying to decipher what must have been the political conversation happening in the background of this whole thing while we are looking at these policy documents. The second thing that I want to emphasize is that the way we approach things in this paper was that we looked at these primary health facilities, whether it is primary healthcare center or a sub center, or even if I talk about a community health intervention or say a village arogya samiti today, all these they are sort of visible products of a bigger ideological concept, which is widely known as the primary healthcare approach. So sorry. Um, this sort of this bigger ideology, it comprises of many concepts. Okay, of the pro concept of access, availability, affordability, working across sectors, moving away from hospital centric systems, and this set of ideals is extremely complex. It while you weave it all into like an umbrella concept called primary health care, it has influenced the way our health system has evolved in many ways. Also, something like this, it's very difficult to define. In fact, one of my own dreaded questions, say in a PhD viva or even at work today, is if somebody asks, what is primary health care? Because nobody's ever satisfied with or happy with the answer that you get. Further, in India, things become even more complicated because a lot of these ideas that came later in the primary healthcare talks in Alma Ata, they were already there in the original vision that we had for our own health system. Okay, so like the Bhore committee report, which Dr. Mohan mentioned, as all of us know, this report, it came out at the eve of our independence. It lays the foundation for health systems in India. It talks about building this very comprehensive network of primary healthcare facilities, and which will be the foundation of the health system. The report is very interesting to read if you read it from the point of view of, although it's really huge, from the point of view of the arguments it put forth. Okay, why is it that we should invest in health? Why is it that we should use a development approach to health? Why is it that we should build these network of facilities? And it's a little fascinating, especially when I read it from this point of view, because it must have been really challenging for people of that era to lay down such a comprehensive vision and yet sort of know that it's going to be a hard sell with the government given other priorities. So what they tried to do was put some very cogent argument forwards, like one quote which I've mentioned here, that on expenditure and why we should do it in the report. But um, I'm so sorry. I'm just going to use a different version of these slides. Um, I made a shorter version wherein I've cut off a few things. So I'm just going to use that instead. Yeah. Okay. Um, So sorry, we were at the board committee report in 1947, and then we sort of moved on to say what happened in the next few decades. We had this huge vision, but sadly, what really got operationalized in the first 2 decades, from say about independence to about 1970s, was a very dilute version of the board committee report. There was a lot going on for India too. There was war, there was famine, there were post-partition issues, so it was difficult for the government to put the kind of money that was needed to develop this kind of health system. Plus, at the same time, money was being pumped into certain specific issues, like the anti-malaria campaigns were supported by Rockefeller Foundation. We had Ford supporting the family planning, this thing, and others. So, what is seen most prominently in the 2 decades after independence is this set of programs that focus on specific issues which were felt to be of uh, priority at that point of time. And if you actually look at documents in this period, you can see that there were some arguments which were being made to support these decisions. So for example, if we look at this particular sentence from the plan, Government of India Plan 2, it says that yes, we will right now focus on certain issues, but after we attain some control, we will just integrate these issues with the normal activities of a health unit, and then we'll move on. So whatever these people thought at this time, they always thought of this as a temporary solution. Okay, and even during these times, they always viewed Bore's vision as the ultimate vision that had to be reached at some point in time. Okay. And then came the next point, which I thought I'll refer to, is the Alma Ata, which needs no introduction to the audience here. But this tiny sort of two-page document, it remade history in many ways, as discussed like earlier about that the whole concept of primary health care with its focus on health as a fundamental right, as an aspect of development, the focus on equity to make services that are less hospital centered. All this came up in the Alma Ata, and this was also taken up very beautifully in India by then. It was also the time of political upheaval in India because there was coercive family planning happening. The government had almost fallen because of that. There was an emergency, and the emergency had been declared, and PHC sort of it was it's symbolic of the move away from coercion. It talked about all these participatory concept and people's right to participate in their own health. Okay. This was also the time when our first national health policy, the 1983 one, it came up. It's almost a mirror of the Alma Ata in many ways. So it really takes a lot of concepts from on comprehensive primary health care, the whole approach, and that's how the first policy looks like. Okay. Another thing happened in the international community at that time. While there was a lot of support for Alma Ata, there was also an apprehension about how to really take so broad a vision forward. It was felt that this was too huge in scope. Lower and middle income countries may not be able to invest a lot in it. And so instead, another version of the comprehensive primary healthcare was taken up, which came to be known as the selective PHC. It was a more narrowly scoped version wherein of primary healthcare, which was at that time called more rational, more cost effective, with more clear cut pathways. And so many countries took the route of selective PHC at that point to move forward. What happened in India post Alma Ata then was that we did focus a little more on expanding the primary healthcare infrastructure, boosting human resources. But even while we did all this, our PHC systems were still designed only to provide selective services. And it's also important to mention here that there were other macroeconomic changes also happening. So those of us who are products of the 1990s, we would have seen imported cars, everything coming in then. But this was also a time of global recession. There was a move towards cost containment in the public sector, and there was the people were also questioning the government's role in health, and whether we should restrict it even more than what was earlier visualized. Okay. And as these changes were happening, other things also came into being. There were these global health initiatives, which were bigger donors, which came into being, and we had a new set of vertical programs, which were slightly different from the previous ones, which was AIDS control. We had the tuberculosis program, we had the child health program, and others. At this point, we then adopted a new national health policy, and something really interesting is that while the 1983 policy, it was completely on primary health care. The 2002 policy does not even mention the word comprehensive primary health care even once, and there are no reasons given for why we made such a big shift into in the way we visualized policy. And this sort of trend continued till the National Rural Health Mission came in 2005, when some attempt was made to make some what they called architectural corrections in the system, pumping more money into primary health care. The ASHA worker was brought in, the village health and sanitation committees. So a lot of work happened around in the primary healthcare space at this point. Okay. For just summarizing, I don't want to take too much time here. If we look at the history of primary healthcare in our country, we've had these very small spurts of strong operational support for primary healthcare in our country. We've had Bore committee with its big vision, but operationally we've had some small committees putting in money on, say, the village health guide and things like that. We had the Alma Ata, after which there was a spurge of resources into primary healthcare. We have had a little bit because of NRHM and such. But when it really comes to, say, overhauling and strengthening the primary healthcare system. I think if you look at our policies, there has always been one argument or another to justify why it's not been possible. So sometimes it is said that it's not a priority, this is something else, is temporary and urgent. Sometimes you have to make hard choices and there are fiscal constraints. But every time there has been an argument to justify why we can't do it. And all these choices together have resulted in the kind of primary healthcare system we see today, okay, which is very familiar to operating on a few things, which is highly target based in its approach. Our system is culturally used to being underfunded, and even our community, they have sort of gotten used to not getting too many services from the public sector, and they don't and the expectations are very less from what we provide. The current move towards primary healthcare, it's intended to change that, but I think that is something more that we are talking about today in the next sort of discussion. But I would thank you as I stop. I also want to say there are bigger stalwarts than me who have actually lived this history of primary healthcare. For example, Dr. Mohan, I think you can say all this in your sleep, but I also acknowledge all those great mentors as I end this presentation today. Thank you.
Thank you very much, Dr. Amni. That was I think, a beautiful recollection of
Mhm.
how primary care has evolved, and also I think you're kind of underscoring that it doesn't happen in a vacuum, right? I mean, there are macroeconomic forces, there are political choices that are made, and that leads to the evolution of a policy like that for primary healthcare. I think this is a good time for you, Ritika, to come in. While Dr. Amni has talked about how it has evolved, you have been watching the public systems closely and researching and understanding over last few decades, in many states, but also in Rajasthan, where I think you've also looked at primary health centers over the years. How have they been functioning? What is the needs that they are filling or not, and what are the strengths and issues that they have? So over to you to share some of your research over the years on the status of primary health centers and the services they offer.
Thank you for the invitation. I always feel a bit uh, underconfident to talk about public health systems, because this is something that is relatively new for me in terms of my own understanding of these issues. So I hope you'll bear with me. I'm also going to start presenting my own screen, so that's going to override. Yeah, thank you. So that I can show. I hope this is visible to everyone. Yeah.
Right.
Okay, great. So let me give a quick background. Actually, one small clarification. We have not been looking only at the PHCs, primary health centers. The study involved going to sub-centers and CHCs as well. And the history to, to this is that in 2002, three economists had done a survey in Udaipur district, and I think they were working with Seva Mandir at that time, or through Seva Mandir at that time. And so they had identified the villages in which Seva Mandir used to work, the NGO in Udaipur. And they had surveyed both public health facilities as well as private health facilities that were available in those villages. So that study by Abhijit Banerjee, Esther Duflo, and Angus Deaton, all three of whom are now Nobel laureates, was actually pretty dismal. I think what they found was not at all encouraging. Um, these centers were by and large defunct, whether you talk about PHCs or even, and of course, sub-centers, even less so. In the intervening period, especially 2011 and 12, the government in power in the state of Rajasthan had introduced two major initiatives in the health space. One was first, I think it was free medicines, that basic essential medicines would be provided free at public health centers. And then a little bit later, they had brought in this reform, this whatever not reform, but whatever, they had introduced free diagnostics with a bunch of basic diagnostics also being made available at all the health centers. So when that was announced is when we thought that maybe it would be worth revisiting the centers that were the health centers that were in the earlier study to see how they were doing, because we happened to have a baseline. And so that's how we went to Udaipur in December 2013 with a group of students. And what we did actually, they were very kind and they shared the data set with us, but it wasn't in very great shape. Anyway, we were able to at least reconstruct by and large the full list of public health centers. We didn't go to the private health centers at all. But we did manage to visit most of the public health centers that were part of the original study, which included some sub-centers and some PHCs. And then we also, I think, added some CHCs since we were there. And then again, last year, not last year now, in July 2022, we decided to revisit again the same centers that had been already studied twice. So what I'll present is basically primarily actually the change between 2013 and 2022, because already between 2002 and 13, we had seen some improvement. What we had hoped to capture at that time was the effect of the free medicines and free diagnostics. But as far as the free diagnostics were concerned, we went too soon after the reform was, or the policy was announced. And so most places were still putting things in place. And so we thought hopefully by now we'll see some effects. So let me move. So this is work with Jean-Dres and Rishabh Malhotra. The three of us had organized this survey. Yeah, and I should add that basically in 2013, when we were doing this, we also then later on did an informal survey in a few other states, Himachal Pradesh, Bihar, Jharkhand. And this year, this last round, the third round, we added Chhattisgarh as well, because we had been hearing about a lot of work in the state of Chhattisgarh on the public health system. So I won't talk a lot about these other states today, but I will bring them in just a little bit to give a comparative perspective about how things are. So I already talked about this older background, and essentially actually our questionnaire, such as it was basically using the IPHS standards that are supposed to apply for these public health centers at different levels. And we didn't do a full sort of checklist, but we did a substantial subset of the questions, and checking whether the norms that are prescribed for PHCs and subcenters are actually being met on the ground. So what I'm going to present is basically very simple change over time on these metrics. So this is the sample. Again, I won't spend too much time on it. Maybe the relevant row here is the Rajasthan row, and maybe I should put it on. Yeah. So if you can see, Rajasthan only has Udaipur district, and the reason for that is because the original study was only in Udaipur, the subcenters in rural Udaipur. We have 13 CHCs, 22 PHCs, and 65 subcenters. Some of the PHCs and subcenters, they get upgraded. So those are the numbers in brackets. It tells you how many have remained at the level at which they were in the previous round. So out of 22 PHCs that we have in Rajasthan, 19 were PHCs in 2013 also. Yeah, so there's been no change in the status, and the rest we can skip for now. This is just to give you a sense of how things are on the ground. So there are some or many, I would say, health facilities which are functional and provide decent health facilities. So these are photographs from a CHC in Jharkhand, and you can see that it is reasonably well used. One is a lab, one is vaccination services, and I think the third one is OPD. Then there are some where even though the situation is pretty grim, somehow because the staff is quite motivated and dedicated, they still manage to provide some basic facilities, health services to their patients. So the one on the right is actually a center in Rajasthan, and you can see that it's very difficult. There's like these rubber sheets on the ground because the rain had ruined. It had caused quite a lot of trouble. The other one is from Himachal Pradesh. And then there are many where things are just not functional at all. So you can see a labor room where there's a seepage issue and there's water dripping. Residential facilities are a big issue on the ground for many people. And again, the wards were in very bad shape in some places. So in Rajasthan, in all, we covered about 100 health facilities over this time period. We have a sort of panel, and they are spread across 8 blocks of the district. And we were able to revisit most of the ones that were surveyed earlier. So this is, like a brief overview of the change that has happened in the past 10 years. And maybe it's worth going through some of these, not every single one of them, but certainly some of them. So you can see that the average population served between these two time periods, there has been some improvement, and this is within the norms that are set. I think it's 30,000. It's supposed to be 30,000. The proportion of PHCs, so this is PHCs. There are some slides later on which talk about the situation at the sub-centers. This one is about the PHCs, the 19 PHCs which were PHCs in 2013 and remained so in 2022. We find also some improvement in the proportion of PHCs that are open at the time of arrival. So in 2013, about a quarter were closed, and in 22, this has gone down a little bit. Generally, you find some personnel or some health staff at the PHC when you arrive. The proportion of staff present and even doctors present, proportion of doctors present, both of those indicators have improved over time. But this is one of the persisting problems, I would say, that even though there is an improvement, it's not nearly good enough. And I'll talk a little bit more about this because both these things are a little bit complicated, both at the PHC level, but much more so at the subcenter level. The other big improvement that we noticed in this period is the footfall at these health centers. Let me skip one row for now, this one. We'll look at OPD cases in the past 7 days. There's been a substantial increase. And the patient utilization rate, which is the weekly OPD number divided by the population served, which was about 5 per 1,000, has improved to about 11 per 1,000 in this period. So I think generally this is an indication that people are going to these sub-centers much more than they used to. And if there's a chance, I'm just going to show you some NFHS data that is also interesting to look at. In terms of deliveries, there's a bit of a decline. That's, I think, primarily because PHCs no longer do the deliveries. People tend to go to the CHCs and other places higher into the hierarchy because those places have become much more easily accessible to the people living in these rural areas. So in general, when the patients arrive, they tend to be attended. They are not kept waiting, etc. Because that's another big worry when people talk about the public health system, is that they're not treated, or they have to wait very long, or they're made to wait, for not for reasons that the doctor is busy and looking at other patients, but just because the doctors are not accountable. But generally, we find that patients do get either a nurse or a doctor to look at them when they go there. And this is the other big improvement, quite dramatic actually. which is that nearly half of the patients were being charged in 2013. But we find that hardly anyone now reports being charged. So we just talked to a few patients who were present at these health centers when our teams arrived. And then outside the health center, when we were away from the hospital or PHC or whatever staff, we would ask them, how they had been treated. So these two questions rely on both observation as well as conversations with the patients themselves. And then the remaining indicators are basically about the facilities that are available at these PHCs. One problem that we found is that PHCs that have all three things, what very basic things, water, electricity, and toilets, was at about 68% in 2013 and has gone down dramatically by almost, it's gone down to about 42%. And the big spoiler on this was electricity supply. So we were there during the monsoon, where the situation was really bad. Like a lot of the infrastructure, the problems with the infrastructure in Udaipur rural were really like, out in the open because of the monsoon season. And if there's time, then I can show you some photographs. In terms of residential facilities, also there hasn't been any improvement. But in terms of free diagnostics and free medicines, basic medicines, by and large, we see an improvement across the board. And what we find is that the range of diagnostics and medicines has also expanded in this roughly 10-year period. Now, I can see that I'm running short of time, so maybe I can skip a little bit. I can skip this one, which puts Rajasthan, in comparative perspective with the other states that were in our sample. But maybe the one thing to say is that it was not the best in our sample. Chhattisgarh, which is a new kid on the block, where of course our sample size is quite small, does much better on almost all indicators, except perhaps patients being charged. I think there was some cases of patients being charged a small kind of registration fee. And Himachal, of course, in the previous round had also been one of the best. It's one of the states where public health services are the main port of call for all patients. And this reflects in the NFHS data. So whatever little time I have left, I thought maybe let's talk a little bit about the sub-centers as well, because just based on impressions, at least for me, suddenly it seemed this time that the sub-centers, there was much more going on. So like, in 2013, we struggled to find or ask about the sub-center in the village, and people gave you a slightly puzzled look about what do you mean, where is the sub-center? That's no longer the case. But somehow these field impressions that I had don't adequately reflect in the data. So what we find is still that many sub-centers remain closed when we go there. There are still many where nobody is available. Only one out of two or three sometimes staff members are present. And like I said, this absenteeism problem is a complicated thing. So let me actually take this opportunity to talk about it. At least at the sub-center level, the ANMs are the main employees there. And in recent times, one big positive change has been the appointment of the CHO, the community health officer. And that's primarily at the health and wellness centers, which has been a recent kind of initiative. And what we find is that generally the health and wellness centers do marginally better than other sub-centers. Not dramatically better, but still there is some sign of hope if actually enough money is put into these health and wellness centers. Because right now it appears to be just sometimes it's just a coat of paint, very cosmetic kind of changes. But in substantive terms, the big change in these past 10 years has been the appointment of the CHO at the health and wellness center. So I'm at 6. I mean, according to the schedule that was sent, I'm out of time. So Can you
You
just let me know if you want me to stop or?
no, I think Ritika, you can take a few more minutes because I think thanks to Sudha, she kind of has gifted you a few minutes. So,
Okay, so we also asked the health workers about how they felt things had changed or over the past 5 years. And so you have the responses of the PHC and CHC workers as well as the subcenter workers. At the subcenter, it's mainly the ANMs and sometimes there's a CHO. CHOs were very recently appointed, so they don't have that kind of perspective. So mainly ANMs were answering. And I think the key takeaway is that most people, so if you look at the bottom panel where the cursor is, most of the respondents felt that things had improved over a period of time. And there are many different aspects of that improvement which they report. So one is that more people are coming to these sub-centers and PHCs. I think COVID had something to do with it, where colds and coughs also started being taken a bit more seriously than they used to be. But even on other things like supply of medicines, people felt, health workers felt that things had improved. Not everything has improved. They still had lots of complaints. So here are the big problems that are reported by health workers. But this table now is all the states together. This is not Rajasthan specific. The previous one was Rajasthan specific. And you can see that the irregular flow of funds is one of the big problems that people are reporting, along with lack of staff still at both levels. So basically, there has been some improvement, but compared to what we had hoped to find, we were still quite disappointed, especially for me with respect to Rajasthan, where there were two aspects. One is that actually the state government has made some serious commitment or effort to make a difference. Some of it, by the way, shows in NFHS data where the proportion of people going to a public health facility has risen over the past 3 rounds of the NFHS. But the other thing for me that was also disappointing with what we saw in Rajasthan is that my field impressions were not reflected in the data. So like I said earlier, that it seemed to me that the sub-centers were more functional. There was a trickle of patients, but someone showed up in the short period of time that we were there, and the fact that they were open and somebody was sitting there was already something. So maybe I'll stop with that, and then later there's an opportunity.
thanks very much, Ritika. This is, I think I am always amazed by the simplicity of your research and yet so powerful to, make some kind of I mean, you can see the data and see that what is happening out there without it being very complicated. Um, so, I'll come back to Sudha, and you had, when you did this research, this was like 2015-16, right? On the evolution of primary healthcare, and since then there has been a new policy and a whole new bunch of initiatives. Ritika mentioned about the health and wellness centers, etc. So have you kind of tracked that what has happened since then and why, and what kind of then lies ahead based on what has happened in last 5-6 years after your last kind of assessment?
Thank you. Okay, so just a heads up that this is my personal opinion based on what I've seen now, working in this space for the last few years also. We've had, as everybody knows, we've had a new set of policies come up. We've had a new health policy in 2017. We've had the whole idea of Ayushman Bharat Health and Wellness Centers. The NHSRC has designed a whole set of guidelines called the Comprehensive Primary Healthcare guidelines rollout, which has many things. It talks about improving infrastructure. It talks about adding a new cadre, more foot soldiers into the system. It talks about improving quality. It talks about the whole basket, the whole selective healthcare that we had. It talks about improving the basket of services there. So in my opinion, and it could be biased, I think these are really important things to do given the choice, given the sort of design choices that we have made. I wouldn't even say design flaws, but the sort of choices we have made in the past, the choice we are making now in terms of altering the design of the system. I think that's the definitely the right direction to go with where we are going with these guidelines. Having said that, these guidelines are not very easy to implement, which is a little bit of a challenge. On the surface, they look easy. You just have to paint health and wellness centers, and you have to add a new cadre. But there is a lot of depth into these guidelines, which I think involves um, a lot of institutional culture change. For example, there are just a few lines which say we need to do team based. Everybody has to work in a team. The governance needs to be beyond the portfolio of health, only health. People need to govern other sectors also. We need to do multi sectoral work. We need to devolve powers to the community. These are all things which are uh, easier said than done, and we all know this. So um, I think a lot more in terms of implementing these guidelines is required, and it's going to be a slow process, and we need patience to get there. Thank you. Dr. Mohan,
Thank
you
you.
are on.
Yeah, thanks. And I think the point that you brought about the work culture, and I think Ritika, you also kind of, I think, hinted towards it, the persistent absenteeism. And I also saw a small proportion of people who reported that they are being harassed by the seniors, though it is a small proportion. But knowing the Rajasthan culture, where people are not very easily likely to talk about what they feel. But talking about work culture, and you also mentioned about Himachal as a place where public systems are much more utilized as compared to other. So two questions. One is that do you see a difference in work culture between Himachal and rest of the states? And second is that uh, how does one tackle this work culture in public systems to improve uh, their performance and their availability and yeah.
Right. So I'm cheating a little bit and showing you that table on, the NFHS data, where you can see the proportion of households that generally use a government health facility when they are sick. And for Rajasthan, it's kind of like around 70 to 75% in this period. But look at Himachal Pradesh, it's even higher. And I do think that, yes, there's a big difference in the work culture between Rajasthan and Himachal Pradesh. Now, why that has come to be, and it's not just in the health sector, it's also in schools and generally. What lies behind this is very hard to understand. I had felt in 2013 that the situation of the health workers in Rajasthan was just so taxing, and they were being asked to do so much. The population that they were serving was so high, and in terms of background support, there was very little. Like, you don't have residential facilities, you don't have public transport available. So how is this A&M supposed to reach all these people and do so many different things for them? I think that has changed a little bit, and that that has, I think, made some difference. Like I said, not nearly as enough, not as much as we would have liked to see. Even compared to Chhattisgarh, actually, I think the work culture there is also better. Another aspect to this is that the women who are in the health system, the female health workers, tend to be more with it. they're much more likely to be there, and they're often doing the heavy lifting. So whether it's the CHC or the PHC, the nurses are much more likely to be present than the doctors. Now the doctors, they say, oh, I'm on deputation over here, I just did a 48-hour shift, so now it's my time, or 24-hour shift, whatever, those long shifts. When they do that, then they get some time off. Now those kinds of things we're not able to verify, but they certainly had these things to say about how the expectation from them was too much, and there was still quite a big shortage of doctors in these rural areas. So I think the work culture, I mean, at least there are certain things that may help improve it. So a bunch of ANMs that we spoke to who were living in the residential facility provided at the sub-center had moved away from it when their own child needed to go to a school, and there was no good school available where the village where they are posted. So there is this complementarity between public services, which we need to maybe focus on a bit more. And at least I have health education and public transport in mind. But other than beyond that, I don't know what can be done, because I think otherwise, at least for the ANM, salaries are not bad. It's the ASHA workers who are given a raw deal right now, and that would also help. And then there's this gender aspect, which was pretty striking across states, that there was really, they're bearing the female health workers at different levels and in different posts are much more likely to be there and with it than the men who tend to occupy the higher posts in the system.
Great. I would like to highlight one point from what you spoke specifically, um, uh, which is about the proportion. I mean, the point that I'm glad that you showed this slide, even if by cheating, that, the proportion of people who seek healthcare from a public facility in states like Rajasthan and Himachal is more than 70%, right? I mean, which is something I think we need to keep in mind. We, by
Yeah.
one stroke, say that public facilities are not being used, right? But if you see that this is the port of call for 70% of population in rural Rajasthan and in rural Himachal still, and there are many states where it
Yeah.
is 70-80%. Of course, the national average comes down to around 50%, but even who are those 50%? Do they have any other choice, etc.? Is something I think we should keep in mind when thinking of public systems. A related point is, of course, that a bulk of preventive healthcare in any case is being provided by public systems and through primary health centers and sub-center, despite all this broken and leaking roofs and all of that. So I think a point that we should just keep in mind. I think on work culture and the perception of doctors, and and I also I think this point that you made about the female health force, it is so important. This was a discourse some 20 years ago. I remember before the NRHM was being set up, a lot of discussions on gender mainstreaming in the health sector, considering that it is the only sector with such large, it's probably the sector with the largest number of women health workforce in India, right? No other sector employs as much. Health, I think education is the second one, but health by far. Now with Ashas, it's even more. But what are the policies and the support mechanisms to support, encourage, and promote, and look at their growth and development is something that would probably be a significant investment that would need to be made. Uh, Coming back, so I think the part of you kind of moved from, I think, from your comprehensive presentation to selective presentation, because I think because of the time. But I would like you to, in this context of the work culture, you also, I remember, did a lot of group discussions with doctors in rural Maharashtra as a part of that study. And there were some very interesting insights from what I read in the paper. So would you like to share that a bit? That what were doctors thinking as being part of the primary healthcare system, and does it have
Sure.
any?
Thank you so much. I think there's also a question on that in the Q&A, which talks about how medicalized how the training for doctors is highly medicalized, but CPHC is advocating a whole new set of alien concepts for them. So how do we sort of balance this out? So to just tackle these two, think some of my work was in visiting health facilities and talking to doctors, because often I think we blame. There's a tendency to blame cadres in the health system for, let's say, being absent, being corrupt, being this thing, not doing the things that a good doctor in a health system is able to do. But we sort of looked at the way doctors were acting in health in a primary healthcare center, not with the intention of blaming them, but say, okay, these are ways in which they are coping with the kind of restrictions and the ideas that have been put on them for many years. For one, their medical training is not equipped to train them for the kind of work in our society has not given value to primary healthcare, that they feel happy being a more social physician, and they have these huge loans going on the background, and other things. At the same time, in that primary health center itself, they've had this big clinical training, and they've have these 20 drugs to work with, which does not make meaning to them. Another thing that they often say is that they have given a lot of administrative work, which they are not comfortable doing. They have not been trained to do it, and they want to do something else. They want to do more. And believe me, a lot of these doctors are also very passionate. They join the workforce with a lot of passion, but being in the system, it has also made them very risk averse. They are scared of what's going to happen to them next. Some of them are just resigned to their roles and don't want to do much more. They just take things as it's happening. A few motivated ones remain, which try to work with, which try their best to work with these scenarios. But even they are highly risk averse. I think our system is highly target oriented. It focuses on them doing certain things, like completing, say, these 3 priority indicators, or doing all the Aadhaar cards of everybody. It's less worried about, we are not rewarding good doctors who are making connects with the community, going beyond their means to have more outpatient clinics, doctors who are referring patients and following up and working. We haven't found systems to sort of encourage these practices in the health system. And I think, Prakash, when you talk about management practices and how they need to get more into primary healthcare, these are all things that I feel are needed in the system, for doctors to cope better rather than just become one more bureaucrat in the system. Thank you.
Thank you, sir, for raising this. I think, and a good point, that we often kind of blame a certain cadre as if, they are working in isolation. There is an environment in which they are working, both within the health system and within the society that they live in. And do they get adequate support and encouragement, etc.? And one of the questions we often ask in our circle is how to glamorize the primary healthcare, right? I mean, how to make it more glamorous, as opposed to being a cardiologist, for example, for doctors, or for nurses to be a critical care nurse versus a primary healthcare nurse. And these factors do affect. So the final question that I wanted to pose to both of you is that where do we go from here, right? I mean, how do we reform the system? There is, even if it is less money, I mean, even if it is 1.2% of GDP, it's still a lot of money that is going on in the public systems, right? And how do we make optimal use of it? How do we strengthen the role of public sector? One is, of course, the message is clear that there needs to be more money in the public by the government spending on healthcare, which is undeniable. We keep reiterating, doesn't happen, but yeah, I mean, there needs to be a certain level. The second is that how do we make this money count and improve the performance of the public systems, which broadly we agree that there is it's primarily the government's responsibility to ensure healthcare for people. Then what do we do from here based on whatever So Ritika, also maybe starting from you, also based on your experiences with public systems elsewhere and other campaigns of reforming public systems.
Right. So you've taken away my main answer, which is to put more money. And I think actually more than the money, we need political commitment. And with this general election coming up, it would be nice to see people talking about health systems rather than the things that are getting talked about right now. I mean, that is a very big concern, right? That we're just not talking about the issues that matter anymore. We're just getting diverted into all kinds of random stuff. So that's one big picture kind of thing. Be great to see a right to health kind of thing making an appearance in all the manifestos of all the major parties. And then I had little kind of things about which may seem really like stupid to talk about, but for instance, one of the things that we saw and which seemed like it was heartbreaking to see is just the waste of the physical infrastructure because there isn't enough maintenance. um, so I think the way the budgets are done is there's quite a lot of emphasis on capital spending and not so much on revenue expenditure. And so that means that you can't hire a guard, a security guard, and then the building may get vandalized, the fans may get stolen, tube lights may get stolen. So there are little things like that. And even within this, budgets for maintenance of these buildings, which are being constructed all over the country, if they're not maintained, then again, it's a huge waste. And please let me cheat once more, and hopefully for the last time, to show you, I mean, just see the state of these buildings. I hope you can see the slide. So the one on the left, you've already seen how the room has been flooded. How can you expect any nurse or doctor to work in these areas? Look at these buildings covered with algae, and the other one, there's huge seepage problems. This is the condition because there is no cleaning staff available now, according to the expenditure norms that are provided. So it seems like a small thing, but I think it matters in fixing or helping to fix some of the system. One other small thing which came up a little while earlier, which I would have liked to talk about, which is about sort of related to work culture and this gender aspect. I think there is a possibility of kind of building a career ladder into the system so that an ASHA worker can maybe hope to become, depending on her performance and years, etc., and education level, maybe she can become an Anganwadi worker and then become an AN, be trained. There should be in-house training and allow them based on their motivation and aspirations, etc., to maybe become an ANM and even go beyond that. Because a bunch of ANMs and Anganwadi workers, they do talk about like, I'm doing this for 20 years, 30 years, whatever, and there should be something for me to, if I am performing and if I am ambitious, then those kinds of career ladders and better terms of service across the board. I mean, the ANMs are kind of all right, but better terms of service even for the CHOs who were currently being just employed as contract workers. I know there is a fear of making people permanent in the public sector. And indeed, it is accountability is a problem, but we should find ways of making them accountable. If nurses and teachers can show up for work in Tamil Nadu and Himachal Pradesh, surely they can be made to show up. And someone actually put in the comments that the fact that in Himachal, I used the word flatter, but they had used another term about Himachali society, and that's perhaps why the system works. So now that kind of thing, of course, we can't force in the North Indian plains where hierarchy rules. But I think there are other ways of making people accountable. So I would say these thinking about terms of service and also not just always finding fault with them, also trying to appreciate and show something in the system to help them flourish. And then the other is thinking about expenditure norms so that there is some flexibility to maintain existing infrastructure and also employ the kind of staff that is required to keep the facility clean and secure.
Thank you so much, Ritika. It's kind of back to basics, really. Yeah, I think it's common sense that.
Yeah,
Sudha?
but these kinds of things nobody likes. If you say use mobile phones to ensure that the doctor shows up, it's kind of like, अरे यार ये तो बड़ा boring है. कुछ नया, do something big and new, like do biometrics. But if you can get away with simple technology, why do you want to use a hammer? No?
Yeah. Thanks. Sudha, some last kind of words from you.
Last words. It's always an honor to give last words, but after hearing Dr. Khera, I don't know if I have much to add. Um, I think we basically, as we saw historically, we have a highly top-down, target-oriented system, and now we want to change it to something that's more participatory, more PHC-oriented, with all the ideals that we have, and that change is never easy to do. So I would say at macro level, the big and implementing PHC is highly political, as Dr. Kheda pointed out. So at macro level, I think the political commitment needs to be make these roadmaps, be patient to see what rolls out, put in resources and see what happens. At the more meso district level, I think there's a lot of implementation support that is required, and a lot of this is around, I think, change management. These are difficult changes that we are trying to bring about, and and helping people through this. A lot of implementation research will really help to see, okay, what is happening to these policies that we are designed, not to make to find faults with them, but how do we tweak them so that they suit the state context better. And I think there are other small things. I think CHOs need more training. They need more integration into the system. If I talk about in more managerial terms, and also the just to respond to the NCD burden, we have a lot of burden in India, not just NCD. We still have maternal and child health. I think there were a couple of questions around that. We have NCDs. We have newly recognized diseases, emerging diseases. It's a very complex burden. Snake bites, and Dr. Soumya Deep's work is all about snake bites. Vikas Kesri's work is on burn injuries. So all this is also important in our system. So our system has a lot to handle, and the very fact that our health workers are even doing so much, given the kind of support they've had, as Dr. Khera showed us, this is, I think, kudos to all their hard work which is going on. That's all from my side. Thank you again to all of you.
Thanks. So I won't even try to conclude this session. Thank you very much, both of you, and I will leave it to Prakash to then say the final words and well, yeah, welcome for the next session.
Yeah, I think a lot of final words already. I think very enlightening. I would say very engaging and enlightening webinar today. I think we've kind of seen the evolution of the public healthcare system, and again the research from Dr. Keda on the on how some of these centers have actually been shifting, changing, right? So it's been really enlightening. Also want to thank all the participants who took time out during a long weekend today and joined us. Do keep joining in. This is going to be a dialogue series. Thank you again, and have a wonderful evening and a wonderful weekend.
Thank you.